Okay. Kasama po natin yung ating po mga partner agencies from different national and private po. So, to start, may I request everyone to stand for prayer to be led by, hanap na ako sinong prayer. Ma'am Eden, for the prayer po.
Okay po, and let's bow our heads into the presence of our divine God. In the Father, the Son, and the Holy Spirit. Lord God, we thank you for this day. Thank you, Lord God, for waking us up. Thank you for allowing us to see your creations. And once again, thank you for the life na patuloy niyong pinapanam sa bawat isa sa amin. Maraming salamat sa lahat ng biyaya na binibigay niyo sa amin at mga grasya doon undeserving kami at times. We thank you for always being there beside us sa lahat ng mga struggles and trials na dumadating sa buhay namin. We thank you for always being with us sa aming mga trabaho. Lord, this day, we lift to you our activity. Sana po kayo po yung manguna sa lahat ng aming mapag-uusapan. Tulungan niyo po kami sa mga desisyong gagawin namin. Sana pagkalooban niyo kami ng bukas na puso't isipan at ng tamang pakikinig para po sa aming mga gagawing activities. We pray and believe to you, Lord God, yung lahat po, Lord God, ng pagkakasunduan sa araw na ito. Naway kayo po, Lord God, yung manguna sa lahat ng gagawin namin. OTC, ask and pray in Jesus' name. Amen.
Thank you, Ma'am Ellen. Pwede na po tayo umupo. So muli, welcome po sa ating multi-sectoral meeting. To start with, may I call on Dr. Dean Palaka for the welcoming remarks.
Good morning, good morning to everybody. At morning sa mga ka-family po namin sa PhilHealth office. At si Dr. Resto, na ilang taon ko nang din nakakita. Pari pandemic ko pa yata din ako yung nakatuwa. So, anyway, yung iba dadating pa rin mamaya, Kasi marami pa dito dapat na makaupo dito, and other stakeholders. Nagpapasalamat po tayo sa kay Ma'am Ann. Talagang ilang gabi na ito hindi nakakatulog, At kay Doc Ralph, na pangatlong araw at ilang years ka pang may iwan dito sa PhilHealth office, hopefully, na ito na yung father of Universal Healthcare or foundation natin. Anyway, for the last 2 days na nandito sa sunlight at nandito yung kaharap natin, yung ating TV core team, si Ma'am Joy, si Ate Kat, si Dr. Sandrano, si Ate Gina, si Joanne, at yung kabila nating mga kapitbahay ng Hospital ng Palawan, headed by Dr. Reston. It's good to see you again. Yung nakapabalik ng PhilHealth office, hopefully. And wala yata ako natatandaan. Tumatandaan ito ngayon ako. And to Sir Kevin Lee. Sir Kevin, good morning to you. And thank you so much for the next hour, and then to your team that is here that will be discussing about this activity. It is a new one. Actually, marami na tayong mga TV systems, meron tayo sa Department of Health, but it's the TV information system na hopefully maging very, very successful at magamit natin in Puerto, Princesa, and for years to come, ay talagang maging ma-integrate natin yan sa program po ng tuberculosis, And we hope for this one-day activity ay maging fruitful at kapakinabangan po sa ating mga stakeholders at sa ating mga family ng PhilHealth office. At kay Ma'am Eden, kay Ma'am Joy na nandito, and to Ma'am Ann again, thank you so much po. And welcome everybody. Good morning po.
Thank you, Doc Dean, for the welcoming remarks and parang introduction na rin po ng ating pong mga participants. Meron po bang hindi nabanggit? We have po from Hospital ng Palawan, Dr. Janet. Good morning po. From City Peso, sir. Your anak dito, Humaran Junior, from Sangguniang Panglungsod, we have Sir John Ken. Good morning po. And from PMMG Co-op Hospital, we have Ma'am Maria Cristina La Rosa. Good morning po. And syempre po, from the City Health Office, group po, unit team, we have Dr. Susan Zambrano and Ma'am Regina Povillapa, Ma'am Crappy, and Ma'am Joanna Ni, Ma'am Joy Chanson. Yan. Good morning po. And to start with po, bakit tayo nandito sa Sunlight Hotel, no? Bakit po may ganitong activity? For the overview of our activity, may I call on Ma'am Analiza Herrera. Our all in na po. Hindi ko naman sabi kung anong position ni Ma'am Ann. Since siya na po magbabanggit, Ma'am.
Master of none. For whatever purpose it may serve them best. Magandang umaga po ulit. Although yung iba po ay mga kasamahan namin na sa City Health Office and we're expecting na yung multi-sectoral coordinating committee na binuo po nun sa PhilHealth ay a-attend din ngayon. May mga representatives po and we recognize the presence of our representatives from different offices. Ngayon, for the past 2 days po, ay nagkaroon ng workshop para sa Healthcare Providers Network. One of which, ang isa pong ina-expect ay magkaroon ng isang maayos na referral system from the community level hanggang po sa atin sa mga facilities na hinahandle po ninyo and na-manage ninyo. Tapos nag-emerge po na ang isa sa mga prevailing issues ay yun pong wala nag-exist yung referral pero walang maayos na mechanism. Paano natin na-determine kung yung na-refer na pasyente ay nakarating, nabigyan ng serbisyo at saka nakabalik sa kanyang pinanggalingan na talagang totally cared of. Wala po tayo nakikita ganung picture. At ang isa po sa dahilan kung bakit naging ganun ay we usually use the manual. Yung mga manual referral, tapos kahit na merong patients refer back, kahit ako hindi ko po personally naranasan yun, na dinala ko yun dun sa unang doktor na nakausap ko. Diba? Kahit anong treatment na binigay sa akin, unless babalik ako sa the same doctor na nagbigay sa akin na treatment. Parang wala talaga nangyari ng pagbabago. At sa mga agency na kasama po natin outside health, makikita din po natin kung ano yung relation, halimbawa, City Peso, yung ibang agencies like the PhilHealth, paano po yung mechanism, o kaya from the DepEd or community, nasa school, paano nila i-refer yung, particularly sa case po natin ngayon, yung TB patients. Kasi halimbawa, may employed na under ng City Peso, no, sabi nagbibigay ng technical support sa mga local business sector natin dito. Pero walang tatakbuhan yung pasyente just in case wala silang alam na protection, paano i-manage yung case nila. At kung paano naman mabibigyan ng City Peso, yun ang procedure na ito. Pag may case po yun, kasi sila pinag-orient, pag may TB case po sa inyong opisina, ito po yung proseso. Wala pong ganong maayos na mechanism. And even within the facility itself, tayo parang ang nangyayari po, ang level of coordination is level of friendship. Depende sa level of friendship. Kung may kakilala ka doon, maire-refer mo na maayos. Kasi alam mo na meron ka kakilala doon at directly mong nire-refer sa kanila. Paano kung wala? Ano na mangyayari sa pasyente? Kaya po yung isa sa proposal ng City Health under ng Tuberculosis Implementation Framework Agreement ay magkaroon ng system na makakatulong, which is the information system na makakatulong po sa atin na hindi man natin ini-aim na talagang totally paperless, but then makikita natin from the start na pag-handle ng pasyente hanggang sa makauwi si pasyente and the continuum of care ay na ipoprovide without us leaving from our facilities. makikita na po natin, na-handle na siya ni Dr. ganito. Nabigyan na siya ng treatment, ongoing treatment siya. Kasi minsan, lalo na po sa mga doctors, ano na nangyayari doon sa pasyente? It's nakan sa naiiwan siya sa ating kaisipan. Pero pag nakikita po natin na meron tayong update na regular, nakikita natin, ay ito pasyente na to, nagkaroon pa pala ng other cases. Kasi meron tayong ginagamit na system. Ngayon po, at dahil doon, nagkaroon po kami ng pagkakataon na mag-commission ng isang developer ng system na yon na makakatulong sa atin. Introductory lang ang sa TV program. Kasi napakaliit kung population lang ng TB patients ang i-cater ng investment na yon. Actually, niraise po yun ni Dr. Paul. Sabi niya, paano yun? Kasi pagdating ng pasyente sa amin, hindi na namin alam kung ano nangyari sa kanya. Tapos, na-refer sa ibang facility. Yun nga, dahil sa kung di mo alam kung sino na nag-handle, wala ka nang, your service ends there. Wala ka nang idea doon sa pasyente mo. At dahil doon po, tinitingnan namin ang possibility at yun talaga yung focus in relation sa universal healthcare. TB program development, yung TB information system development is an introductory para po sa mas malawak na pag-cater natin at pag-handle ng referral mechanism in a systematic way using the current technology. And for us, na magkaroon ng idea, ano ba tayo pinagsasabi niya? Ito po yung isa sa developer, is already a resident of Puerto Princesa, adopted son of Puerto Princesa. He's been an active member po ng NGO, na Single Drop for Safe Water, na unang-una nakilala po namin siya sa WASH program. Pero eventually, lumawak po yung partnership namin hanggang sa yung mga needs, local needs ng City Health Office ay nakikita niya rin. And since taga-Puerto siya, nung una ayaw niya gumawa ng project sa Puerto kasi tinuturing niya daw ito na resting place. Ibig sabihin, magpapahinga siya dito, wala siyang gagawin kasi pahingahan niya lang. May mga projects po sila since internationally recognized po sila as responsive. Pero ngayon sa pagkakataon ito yung mga tinutulungan po nila sa areas natin. Because they find it necessary for LGU to start with an information system na reliable and at least makaka-address dun sa mga gaps natin pagdating sa mga information and communication. Hindi ko na po patatagalin. Kasama po natin yung si Kevin Lee to give you an input how the system works using the TB information system, an introductory for the universal healthcare. Kevin, please. Go ahead. Thank you very much.
Magandang umaga po sa inyong lahat. I don't need the microphone, do I? Yes, I don't. Okay. Just two things. One, I'm learning quickly, never answer the phone when Analiza's name pops up on it. And number two, I'm a plumber, not a data person. But we do have a joint venture with Roots of Health, which I'm sure you're familiar with, and DSA Software Solutions, which is a programmer based in Puerto City. So we developed the VIMS IR system. We're now in the process of developing the comprehensive household information system, etc. So as Analiza said, we identify areas where LGUs need help to be more effective, particularly in the health and WASH sector. So this is the preliminary outline of how we're going to do this. So this is the steps within the system. The system is cloud-based. So all of the data is stored in the cloud, which is actually a server somewhere using Amazon. So all of the data is available off the internet for your use. It's encoded, it's safe, and you'll be able to input data into the cloud and take data out. So the system that we have, when we track it, so here, somebody is referred by one of your physicians or by one of your clinics to say this person may possibly have TB. So at that stage, that person enters the patient data and issues a QR code, right? So that's an identification card for them in the TB system. They enter all of their personal information, gender, age, blah, 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 right? And some of the medical things. So now the patient has a QR code. The doctor or the referral schedules an appointment. So on the system, they can schedule an appointment for the next, which is the doctor's visit to determine if the doctor thinks it's TB. So when they schedule the visit, it will send out a branded SMS to that person to say, you have an appointment at this location at this time. So the person goes to their appointment, they present their QR code, and it will bring up all their personal data. The doctor can do the consultation into the doctor's notes, into the system, and they can schedule for the X-ray or discharge. So if they say, no, you don't have TB, you have a broken leg, go to hospital, they'll discharge them from the TB system. If he or she thinks that the patient has TB, they can then refer them to an X-ray, and the X-ray will be scheduled. And they will get an SMS saying, you have an X-ray, please be at this location. So they go, they present their QR code, it brings up their details, they take the X-ray, and they look at the X-ray results, and then they can refer for discharge or schedule for the sputum test. Goes through the same procedure, enters the sputum results for the type of, and figures out the type of treatment or discharge, and then the doctor can schedule for the visit. So all of this is every time the patient comes in, they present their QR code, it brings up their record. So whoever's there knows that the person is there. It's always in the system. You don't have to keep filling out forms. So if that person has TB, then it just continues with the treatment. You can do the prescription and the follow-up visits, and every time you do the follow-up visits, QR code, enter the data, etc. Well, does that make sense? Yes, no, maybe. So the other thing is that we also have an inventory management system. So obviously, when you do an X-ray, you'll use plates. You'll take the plates out. The inventory will be changed. So you will have an inventory management system for X-ray, sputum, and drug inventory. So you'll know. So Johnny, you're in charge of all that, Eva. I'm sorry. But your system, you'll be able to know when you need to reorder, right? So we can actually put in here alarms. So when it gets to a certain level, it says, Johnny, order this, and order this. Right? And then all of this patient data is stored in the cloud. So now we can have dashboards. So for the dashboard, the doctors will have access to their patients. So when the doctor comes in, when the patient comes in and they scan their card, it'll bring up the dashboard for the doctor to say this is where the patient is in the treatment system. So we'll figure out what data they need. And then they'll be able to sort which patients it is, etc. And then there'll be a management dashboard so that Johnny and whoever's in charge of the TV system can track month by month or week by week what is the status. So they'll be able to look and see what the inventory status is. They'll be able to see how many patients have been referred, how many patients have TB, how many patients have had x-rays, all of that information. So you'll be able to pull that up and be able to look at that on your computer or your phone. And then we can export files. So you can export Excel spreadsheets that will be able to give you individual or collated data depending on what you need it for. So you can have manager reports, doctor reports, patient reports, and also what we want to do is, depending on the systems that are used by national government, you should be able to download and upload to the national system. The issue is we've got to find out what the format is, which means we have to talk to somebody. But that's the system. All the way through. Questions, comments, violent reactions? Helpful?
May I ask them what is the name of your system? Like
Whatever you want to call it. It's a TB information system. Now we can call it Juan or Henry, whatever you want.
As of today, it's being told as the information system.
Right. So the key points are, one, the technology that you need is like a smartphone or a tablet and connection to the internet. Managers would be able to get information off the internet through their laptops or desktops. The other key point is that the patient doesn't have to fill out all the forms again and again and again. The QR code is that information. The scheduling system by SMS will allow you to track if you've actually contacted the person and make sure that they know that they should be here. It's branded so they don't think it's a spam. So I think Ms. Eden, you texted me at about midnight last night saying, come, somebody here texted me and it was just a number. And when it's just a number, I don't really look at the text because there's so many spam texts. This will be branded, so you could say TBIS, Puerto, Princesa City, or PPC. All of the data that goes into the cloud, it's encoded going there and coming back. Access to different types of data depends on your user access. So we would manage that access for you. So the key is that at different levels, say for here, their access is very basic, just to enter data and print out the QR code. But if you're a doctor, you would have access to all the patient's data. So if you're a doctor, you would have a specific password, and that would give you that access. So you have a username, you have a password, and that gives you that access. We would have a hotline that you can call for assistance. So if there's an issue, and then we'll have a field person available here for issues in the field. We will commission this side by side with you as we develop the user interfaces, as we develop the system. We will work with the people using the system in the different areas to come up with the most user-friendly and intuitive way of entering data. So it must be fantastic. Okay, now, gentlemen, that's what you wanted, right? Okay, we're cool. Right. Okay.
Probably this baka gusto ko rin yung magtanong, paano, halimbawa, ito po ay, is this already cut in stone, the system, or is there any chance of expanding it or other ways to improve, like probably the other hospitals can give some inputs, kasi our system is designed primarily for public health.
Right.
And it was also asked ni Dr. Rob kung how can the hospital can really access and their limitations in using the information system.
So that will depend on the relationship between the LGU and the hospital. So basically, if the hospital wants to enter the data and have the data for their private patients, private TB patients added to the system, then we would look at working on, they would have the same user interfaces as your people, different username, different password, different level of access, right? So they could use that system depending on, so we can work with you on that. This is not set in stone yet. The first thing we'll do in the process is we will come up with what we call an inception report. The inception report will detail the scope of the project. And it will detail what are the functions. So we will sit with you and determine who will have access, what level of access, what is the type of data that is needed, how is that going to be reported. Once we agree on the inception report, then we'll start building the model. We'll start building it and testing it in the field with you. And then once we reach a point where it's usable, the LGU will sign off and say, yes, this is acceptable. And then we'll run it. We can actually start with real data at the beginning, depending on how many patients. So that we can test it all the way through. So you can run it side by side with your manual system until it's working. And that will allow us to debug the system. It's a little bit less hectic than the VIMS IR, which was, as we used to say, it's like designing an airplane or building an airplane while we were flying, because everybody was changing the rules. But with this, it's not a huge system. The other thing is that Ms. Ann was talking about how this relates to universal healthcare and the fact that the LGUs are now becoming primary physicians. And so the same kind of flow, right? It's the same kind of system. It's just much larger data set. So the TB system, if we get this working, that'll be a way that we can then expand it for universal healthcare. We can add in different functionalities. So like, instead of just having referrals for the X-ray, you can have referrals to hospitals, specialist consultants, etc., etc. So a much bigger system, but the principles are the same. And the key is that the patient has a QR code and doesn't get RSI filling out their name and address 473 times. So, yeah.
Sir Kevin, I was wondering if this system is just applicable for within internal facility or even external.
So it's external. So as long as people have access to the internet and the tablet or the phone, they'll be able to use it. So for example, if the doctor is working from home. So if the doctor is working from home and they're doing teleconsult, so they're talking to someone that's in a far-flung barangay, they will be able to access that patient's notes at home, as long as they have internet. The clinics, depending on who's doing the referral, if it's your barangay health clinics or whether it's your satellite clinics, as long as they have internet connection, they'll be able to put in the data and print out the QR code and start the system rolling.
And so, for example, if I'm working at a isolated rural health unit that doesn't have an X-ray, but we do have a TB dots clinic,
Yep.
and I will be needing my patient to have an X-ray, I could just enter that system and refer that patient to a district hospital, the nearest district hospital.
You could refer it through the system, yeah, so whatever access, so for the system here, currently we're looking at designing it within the LGU system, so the LGU X-rays. But if we decide it'd be a bit more difficult to schedule them for a private hospital because they have their own system, right? But maybe there's a way that we could actually have it so it flags for someone to make the appointment and it records the appointment that's been made for a private consult. So that's something that we can work on during the inception report. So during the inception report, what we'll do is we'll draft out what we think it looks like. And then you will all tell us how badly we've done and where we can fix it. And then we'll look at the different options. Options between public and private healthcare system is difficult because they have their own system and integrating it into that won't be possible. But as far as we can figure out systems that will bridge the gap. So how do we trigger it? So maybe you have a point person at the private hospital that's on the system, and when they get a private X-ray schedule, it goes to them and they pick it up on the TBIS, which they have access to, and then they can schedule it within their hospital system. Any other questions or comments? So do you think it'll be useful?
Yes.
It'll make your life easier?
Yes.
Oh, damn it.
How about guidance? She's handling also most of the handling of PhIV, the cases of TB patients with or patient living and
I'm sure you could actually put that in, but the issue is we've specifically priced this for TB, right? However, we can look at other functionalities and then you can add on costs. The issue is going to be if you're trying to connect the private system to this system. So we have to figure out how do we create access, like who has access and how do we put the information in, right?
for the data privacy.
Yeah, well, it's for data privacy and it's also different systems, right? So, for example, the dentist has their own system. And so how do we marry those two together? But we can look and see.
There's a question that was raised.
You're too scared.
And the debt and also other actually the debt and other agencies can access the or the patients as well. How they can access the system.
No. Because it'll be a data privacy issue. Now, So a patient can request for their medical record, right? So you can print it out, but you wouldn't be able to give them access to an individual record. So they couldn't pull it up online.
But how about the application in their cell phone? Are going to, for example, can they register and for the patients like walk in?
You could we could actually put in a scheduling system. So you could have an internet-based scheduling system that would feed into this. Right, so if somebody said, I think I have TB, and they have access to the internet, we could probably set up a web page that says your nearest clinic is this, and you can schedule an appointment, and it would flag this person to say this person needs to, and they can go and schedule an appointment. So we could possibly put a scheduling thing in there for people to say, I think I've got TB, where do I go and set up an appointment?
Kasi that endpoint kasi kung halimbawa, they're going to refer patients.
Right, so you could put up a, so if you have people, yeah, you could actually refer them to that, but you wouldn't have access to any of this. Right?
Just the referral.
Yeah, so you would be able to set up a referral for a person to do that. Online. So the whole system is based on internet connectivity. But on the most part, internet connectivity is going to steadily improve. So I don't think it's a big issue, particularly in 3 or 4 years' time. So on the most part, it will work.
If so we're saying, like for example, what our other sector stakeholders can do is that they have someone that will be able to have an access for referral, which can be seen by us in the city health office for that to be treated.
So for example, in my office, I have somebody that's showing signs of TB. We could set a schedule for the nearest satellite.
That's really good to say. If I'm looking at it, all workplaces should have a TB control program in place. Not only the schools, but also the workplaces should have TB control programs in place. So I guess one of the things that we can do is really to have this to also, if this is up and running, we can invite representatives from every workplace and every school nurses especially to be able to access this one for TB referral.
You can, so my suggestion, so like from private sector, right? I know nothing about TB. So one of the things is you can actually set up a TB website and popularize that site. And so it would have information of symptoms to look for, and then a guide of how to set up. And then you could have a drop-off page that would say, what's your location? You pick a barangay, and then it'll say, okay, if you want an appointment, you would go to this place, schedule an appointment, and then it would automatically schedule an appointment. And it would notify the clinic that they've been referred. So you can do that. That's apparently really reasonably easy. So that the key is you need to set up the TB information page, right? Because like I downloaded the TV app from national government. And it says, it tells you how to contact people, but it doesn't really tell you what is TV and how does it manifest itself. And so, this would be kind of something that the, city health office could manage.
Other question. Because this is, we will be inputting data, right, for this TBIS. Will we be able to have some kind of, at least, we can export the files, because for us in the city health office, or maybe also in the hospital ng Palawan, we are also encoding in different database. Ano nga yung tawag sa database mo, ma'am? With integrated tuberculosis information system, which is from the Department of Health. So, because if we encode a data here in TBIS, will we be able to at least export that data so that we can also we don't have to repeat encoding again to the national database?
So that's something that we are planning on doing. The issue that we have is we're trying to upload to the system. So we've tried asking, but we can't get anyone to answer the phone. So what we need to know, we do this with the VIMS IR. So we are able to download a report that can be uploaded into the VIMS IR, and we hope that it's a similar system.
So we wanted to have what do you call the term for that?
It's you
The
basically,
library or
yeah,
what?
you export to it's basically a CVS or Excel file, and then you can upload it.
Yeah. What do you call that Excel file for? The generic term that we will.
Yeah.
So if we will be asking the regional to get those data, what do
Right.
you call those?
So basically you can on your dash, so you're a management, right? So
Yes.
on the dashboard, it'll say export. And you can say export what to what system. And you'll just press the button and it'll automatically download the correct file, or it'll send it automatically to the system. So we're trying to figure out how to do that. The biggest thing is we don't know how their system incorporates that data. And so we think there should be an upload. We think it should be that style, but until someone answers the damn phone, we won't know. That's the problem, right? So we've said we know that people do upload data. We know the formats, and so we can do that as long as they tell us what it is.
So what you need are the formats for the CSV file.
Right.
So we'll be trying to get that for you.
So if you can get that to us, then everything else is pretty golden. It's pretty easy. Apparently, I'm a plumber, mate. Okay, now.
Meron pa po tayong mga questions po. Yes, sir. Sir.
May I ask for the estimated cost or budget needed for the implementation of the program, sir?
We've put in 3 million pesos for, basically it's a 24-month implementation. So it includes all the programming, all the storage, all the management. We think that within between 3 and 6 months for us to get the system up and running.
So 3 million pesos for the 24-month of implementation.
And then after that, it'll be just a annual fee. So it'll be you'll pay for because you have to pay for the data storage on Amazon Web Services, and a fee for us to maintain it. So what we would do, so part of that service is we would manage the user interface, right? So at the LGU, you'll have someone that's in charge, So that, if that's Miss Jonama, and she will give us a list of people that will have access to the system and what level of access. And then what we will do is we will give them that access, they will have a password. And then say somebody leaves and is replaced, Jonah May would call us and say, can you replace this person with a new user? So we would manage those things. If there are issues with access or problems for the users in the field, they'll be able to call a hotline to get on, they will be able to get somebody to talk them through the issue, and if it's a real problem, we can go to site.
So 3 million pesos for the 24 months of implementation period and start of the program.
Right, and
Then
then
annual, do you have an estimated budget for cost for the annual?
annually, it'll probably be about, I'm not sure of the storage size, I think it's reasonably small, but it'll be something like between 40 and 70,000 pesos a month.
Okay, so
So it's cheaper than hiring an IT.
40 to 70,000 a month.
Yes,
Annual. So times 12.
times 12, so it's between 500 and 700,000.
Okay, thank you very much.
Yes, ma'am.
Sir, is internet connection is included in the 3 million package?
No.
It's not. Pero
Yes.
Nauna natin, Joy, nakakamit na sa docs yung
Software line.
may partner naman.
You have to bug her for money.
But this is FIFA.
It's, I mean, that's an operating cost for the system, right? So there's no hardware, there's no internet connectivity as part of this program. It's purely software and system.
Can you share the current development status, or just to print it out, or at least for our partners to agree with it that then.
This diagram? Yeah. I can send that to you.
Para they can actually see the areas that they wanted to.
Yeah, I can send you this document. So currently, we're still waiting to sign the contract. So once we get the contract signed, we'll start working on it. We're sort of up against it because we're developing the chips as well. So yeah, we got a bit of work on. But once we sign the contract, we can start the inception report. And the inception report will be based on this project, on this information flow. So this is what we call the system architecture. We'll develop the system architecture. So from today, you've added in an extra step in here, which is a referral from the internet, right? So that's something else that'll be part of the package. Which would be developing the website. And the website would be linked to the CHO, put it on the CHO Facebook so that it links to the website. So that people can access all of that.
May tanong ako. Kaya parang binanggit ni Kevin, wala po siyang hardware, which means wala po yung extra package po na i-request po namin sa kanila ay wala computers or anything, tablets, or wala po. It's just purely the system. And yun po internet connectivity, other than po siya ng ngayon at ulit na actually not yung public class po. This year, next year po naman ay meron din po. Tira, different.
Just in case, sir, we have problems, with the system, if we need your help, there any
Yes, no, we'll set up.
extra?
No, so that's part of the monthly fee. So basically, we'll set up a hotline to Clayton. Clayton's not here, so I can use his name. So you'll have access to that during work hours.
Ano kasi, sama po siya, hindi tayo iwanan ni Kevin hanggang sa overall ako. Actually, yun po ang advantage having them here sa Puerto Princesa. Kasi anytime po na kailangan natin ng troubleshoot. And bago po
She
na
knows where I live, that's the problem.
anytime na magkaroon po ng, katulad dito, una sa improvement, may nakita po tayo kailangan or nakita na pwede po i-refine. Pwede na natin iba to sa kanila. Pangalawa, pag may nakita po tayong along the way during the implementation, ay kailangan naman siya troubleshoot at entitled po sila. At yung bago po tayo nila actually i-run through, magkakaroon din po tayo ng orientation sa lahat ng hawak ng system.
So when we develop the system, Clayton will work side by side with John and Mary. And she's the expert. So, like on the inception report, we'll sit down with her and go, okay, what do you need? What do you want? And then that'll be what we'll negotiate it on. And then as we implement in the field, it'll be like what we did with PIMS IR. We'll have people in the field. We'll have Clayton in the field with these small systems, so it's not as hardcore as PIMS IR.
What do you think or how the policy can help us? With us here is the representative of the office of the City Council.
So I think from a legislative point of view, you could look at how you want to interact with the private healthcare systems, how you interact with the Palawan hospital. So that they all input into the system. So we can figure out systems to make it work, so then you can track all TB patients, both public and private. I think that would be key. The other thing is making sure that the SP, when they're looking at long term, and it's not just for the TB system, but also for if we expand this to the universal health care and the CHIS, data collection and management is going to the cloud. And what it does is it makes local government units and health service providers much more efficient, right? So you can imagine, I mean, when Jonah May was showing us the system, how many times a patient has to write down their name, their age, their sex, their address. Like I went in with TB and came out with RSI. But it's one of the things that frustrates me about the Philippines is that every step you have to fill out your name, your address, and it's like, I'm still the same guy I was just over there, right? See, look. So it makes it much more efficient. It means that information can be accessible so you can plan, right? So Jonah May is what might be behind in encoding everything, which means it makes it harder for her management to decide what my budget needs to be next year for TB. So that's why here you have dashboards, which would give you real-time information. You could actually map where the TB hotspots are. So you could actually pinpoint barangays where you have the most TB. So then you could say, hey, maybe there's a patient 0 that nobody knows about that's spreading. Your inventory management will mean that you won't run out of stuff, right? Because you'll know exactly how much you have in stock if you use it right. So the inventory management, when you check out an X-ray plate, you just swipe the barcode and it'll tell you that's gone out and it'll automatically adjust. So all of these things, and then universal health care. supposed to be digitized by in the next 3 or 4 years. It's much of the same components, just humongously bigger. And so, you know, the LGU needs to look at how am I going to manage that? And LGUs are there to provide basic services. They're not there to have huge IT departments. So how do you farm that out? How do you manage that effectively? So those are some of the things from a SP point of view. The data privacy stuff, we're working on that. We're trying to figure out, so we're going to set up our own data privacy office. So that's actually part of the user fee. So that we can make sure that from our perspective, we will not sell patient data. We will not hand that patient data over to anybody. The LGU is the only one that has access to it. And then the contract that we'll have, the user's contract, we'll have to invest in wording that will talk about users when they sign up and when they get a password means that they abide by the rules, which means that they don't share patient data. So I started looking through the legislation on data privacy, and it's scary but reasonable. So just those are the things that we'll have to consider in the long run.
Yan po, may mga questions pa po tayo. Siguro yun po rin sa, siguro sa legislative part. I second that idea po. Because we really don't have localized data protection policies yet. And I think that will severely affect all the information systems, including RTBIS and Universal Healthcare and other programs, because it will also affect, syempre, in a local setting, the data protection components. Meron pa pong questions from the body.
Wala.
Binanggit ko namin kanina, no? Open po yung system for further enhancement and reports na bawat isa. Kaya po, share din po namin ito. Is this the TOR?
No, this is the draft of the, so the TOR is quite open. So it refers, this is how we start to design. Basically, we've said that we're going to design a system that's user-friendly, that tracks patients from the beginning to the end and inventory. So when we build the inception report, that's the time that you have the ability to say, we want to do this and we want to do that, and we can look to see if it's possible. So one of the biggest issues that I see is going to be the integration of the private healthcare system within the system. So that's something that we would have to troubleshoot how to do that, because it won't be a system. It'll allow the private healthcare some access to the system for inputting data, but not taking out data and things like that. So we'd have to work out how to do that. That would be more of a process issue rather than a system issue.
I guess with that, we'll be closing the session. Sir Kevin, thank you very much for the time you spent with us today. Maraming salamat po. Yan po. Let's try, habang ina-observe po natin yung the presentation po ni Sir Kevin Lee, we'll be taking a 10-minute break. Coffee break po muna tayo. And kung gusto po mag-CR po tayo. Pakiusap lang po namin, please answer the feedback form. You just scan the QR code po, it's a papers. So, meron po dyan, one is yung questions form. If you have any questions, may mga questions pa kayo naisip, you just scan the QR code and so that we can still give it to Sir Kevin Lee and we will be more than willing to give you feedback for the answers. And then there's also a speaker evaluation form that you can kindly scan also for the evaluation form. Again, yun po, break po muna tayo. Maraming salamat po.
kung feel nila na kung akala nila TB or mga yung patient na napunta sa kanila has signs and symptoms of TB and wala silang, syempre sa mga barangay health stations po, walang x-ray, walang gene expert. Ito po ang flow. Una po, syempre, history ng patient. And ginagamit din po natin yung NTP referral form according to the MOP. Sasagutan po nila yon. Wala po akong happy. So, from there, i-refer sa accredited na PhilHealth facility. Tulad sa ngayon po, ang una or pilot is the CHO Bayan Health Center for medical management. Doon po, makikita po kasi doon sa referral form kung for gene expert lang, for continuation of treatment, or for enrollment. So, from the CHO po, gagawin na yon, gagawin na yung x-ray, gagawin na yung gene expert. Pagka confirm na TB siya, from the right, for treatment na po siya. Tapos, bibigyan po siya ng education treatment packages. Ngayon po, kung yung patient mag-o-opt na mag-treat sa barangay nila, i-refer back yung pasyente sa piniling treatment area. Ngayon po, meron pong mga cases na from the BHC, may mga unconfirmed cases. Tulad po ng, halimbawa, may signs and symptoms, tapos wala na yung x-ray niya, minsan hindi napaka-vague or negative ang sputum gene expert, kailangan po nito ng further assessment. So, kailangan po natin i-refer sa specialist or consultant. Meron po later on po, may mga list po tayo ng mga consultants na pwede nating pag-reference. Minsan din po, kahit confirmed na TB na siya, may mga complications. Tulad po pag may renal failure, liver failure, or may complications sa heart. So, kailangan pa rin po natin ng specialist or consultant. So, i-refer natin sila sa consultant for treatment. Then, depende po sa consultant kasi or sa patient kung saan nila gusto mag-treat. So, kung sasabihin ng consultant na for treatment, i-refer back po sa CHO for treatment ng TB. Pero kung yung case pala na yon, hindi naman TB, inactive TB, tapos bibigay po siya ng advice, ganun pa rin po. I-refer back pa rin po sa CHO. Ganun lang po. Basta ang lagi pong bagsak po sa CHO. Okay na po. Klaro po ba? So, isa ngayon naman po, ginagawa naman natin yan.
So, base po sa present po ni Doc Susan na po na referral flow po ng ating po mga TB patient, meron po ba tayong concern regarding po sa flow or process? Or may nakikita po kayo from the side po ng ating po sa mga partners agencies, paano po magiging flow din from your end po, from per agency, and then po paano ang refer, yung mga questions po ba kayo? Concerns? From ONP po, Doc. Okay po. Okay po yung inyong referral po between sa PHO, Doc. Yes, yes, sir.
Good morning po sa lahat. My name is John Pulri po from the City Social Welfare Development Office. Klaro po naman na yung yung picture ng flow chart, referral, management referral flow chart. Pero normally ma'am, tanong ko na lang din po on behalf of our department, saan po normally part pumapasok po yung aming services para po sa ating mga TB patients or mga non-patients pa pero subject for at screening yes po.
Kasi po, most of the laboratory diagnostics naman po, libre po sa City Health. Ang nangyayari na lang po, kung merong further laboratories such as ECG, wala po kasi kami noon, or ultrasound, kasi merong mga cases na merong magpipresent sa chest x-ray na pleural effusion, or sa mga further management. Tapos bibigyan po namin sila ng medical certificate for financial assistance. Kaya pupunta sa CSWD.
Sir, kasi previously, may nabigyan kami ng si Dr. Dean ng medical certificate. For livelihood naman yun. May nakatanggap na rin yung pasyente, hindi ko alam kung ano nangyari sa kanya ngayon. For livelihood. Kasi minsan sa trabaho nila nag-absent sila or hindi na sila pwede so livelihood.
So, ngayon pala yung pag-ano po, ibaw din po sa paghingi ng financial assistance. Kailangan bang sumulat tayo sa kanila or para maging na din
Ayun po, pwede naman po.
Kasi
Let's make this an avenue po for those collaborations. So if we can come up with an agreement, we will be facilitating it po. Like, if I will just add po, with the universal healthcare, sorry, wala pong mask. Pero with the universal healthcare, social workers really play an integral part na po. Because social workers will become our partners with the navigation of patients. Kasi patients, syempre, those who are marginalized, like for example, most of our patients na TB patients are the ones really that are marginalized. And syempre, sila rin po may yung kumbaga lack of educational attainment, mga ganun po. And the social workers can play a big part in referring them to where they should be going. Kasi minsan, alam natin na yun nga po, detection, especially sa mga bahay na yung mga patients, mga cases po natin na marami pong tao sa bahay, tapos hindi nakakapagtrabaho, we suspect them na baka meron sa isa sa kanila na may TB. So we can, as early as doon po sa intervention nyo with the household, pwede po tayong mag-refer. Kasi pag once nag-refer tayo ng isang patient in the household, we can, pag nakita po natin na positive talaga siya, we can, pag na-refer nyo po siya sa amin, we can do contact tracing. So to treat the whole family. Yun naman po yung na rin natin is it that we will be there should be an integrated approach kasi nga po, yun nga po, one of the issues with TB patients is really, they come from the more vulnerable groups. So, doon po tayo papasok with us for the education of knowing that this can be probably TB patients, and then yun po provide financial assistance, livelihood assistance, as well as yun po, kailangan din kasi nila yung mga social case studies, mga ganun po. And yun po, probably doon po talaga papasok yung help po talaga with the CSWD. With really is on the early intervention po, early pa lang. So, if meron po tayo mga vulnerable groups, we can refer them early on because we know na baka most of them, or hindi naman lahat, pero some of them will really have a TB. So, doon po tayo papasok. So, as early as knowing na yung household conditions nila, very vulnerable for sa TB, mga ganun po, we can refer them early. Kasi yun po, meron naman tayong, sa amin po, meron talagang, hindi lang siya clinical, meron din epidemiologic, may mga evidences po, na pwede natin bantayan as early po, sa level nyo po, kahit hindi pa po sila nakikita ng City Health Office. Ayun po. So, yun po, as with Dr. Susan po, siguro, do we need ba at the part of the City Health Office, do you recognize na ba yung mga financial assistance or do we need agreements pa ba with that or ano po yung kailangan namin gawin para po ma-recognize na once nagbigay kami ng financial, ng certification for assistance ay ma-accommodate po sila in the part naman po ng CSWD. Ano po sila?
Yes. Mas maganda po siguro kung meron talagang referral letter from ayun po. Sige ma'am. Ay, Doc. Opo. Kasi po, sa dami din talaga ng humihingi sa amin ng financial assistance, madalas tumatagal po talaga yung pag-release ng assistance. But sa mga ganitong cases, maybe the office can do something para ma-prioritize po yung request ng mga TB patients po natin. Just like yung sa aming mga nagda-dialysis din ng mga pasyente na nag-request. So yun, napapabilis yung sa kanila. Sige ma'am. On that part po, I cannot decide talaga. Pero pwede ko siya i-note po sa ngayon and then i-raise ko sa aming department.
Sige po, sa amin din po, we'll take a note of it para so we can do something about it.
Okay. Sige po. Thank you.
Ano po, may mga questions pa po tayo. With the part po ng, siguro, Doc, ang question dito, pag mga students, paano ang referral? Will they go to the PHS or can the school nurse do it or do the PHWs do it just to have a clear delineation para kunwari, what do you think would be better para po, and yun, can we provide certificates na the patient can, yung schooling po ba ma'am, like for example, 2 weeks, is it okay lang ba yun at the part of the DepEd? Ayun po. Siguro, yung first question ko po, kasi nga po, with our patients, TB patients are pag start po ng treatment, diba nakita po natin siya na, nakita po namin at inaalagaan namin. For the, at least 2 to 3 weeks po kasi siya dapat hindi pumapasok kasi nakakahawa pa po siya. So, ano po yung pwede po ba yun? Or what are the suggestions? Or ano po yung pwedeng alternative natin for the learning po ng mga patients? Kasi ang ano lang naman po doon ay nakakatayo naman sila, pwede naman po silang makinig siguro, mga ganun. Pero hindi lang po talaga sila pwedeng makihalubilo kasi po nakakahawa pa sila. So ano po kaya yung ano natin?
Regards to that question, no? If po ang case is for the teachers or for the non-teaching personnel, I guess you can file for a sick leave for that. In regards naman po, if we're going to have a learner na may ma-identify po sila na we have it, pwede naman po sila for now na modular. So I get, actually yun din nga po isang gusto kong erase either heads, kasi parang sa ito naman is regarding sa ARH, na pag-usapan lang din namin ng word. Na, diba, sa
Since si Herrera.
Ah,
Herrera. So, ayun sa siguro pwedeng modular, pang learners. And then, kasi hindi talaga sila pwedeng pumasok kasi contagious siya. So, pwedeng yun po ang gano'n.
Same as COVID siguro ganun
Yes,
din.
yun po sa COVID. Kasi yun din po ang aming, pag may COVID po ang learner and then yung teacher or any kahit po non-teaching personnel, they are also advised na hindi po pwedeng pumasok. Kasi, minomonitor din po sila ng mga nurses na.
Okay, ayun po. Thank you, ma'am. Ayun po. Siguro, we just, at the part of PhilHealth, we really have to provide a certificate na stating that they shouldn't be, for 2 weeks, for 3 weeks. Ano pa ang nilalagay natin? Para for the clarification of everyone, how long, and at our part, how long po na dapat hindi po pumapasok yung patient? Okay?
2 weeks na pahinga muna. Pahinga talaga. Tapos, after 2 weeks, together with the record po, babalik sila sa City Health Office. Tapos, ang ilalagay sa medical certificate, yung diagnosis, final diagnosis, tapos ongoing treatment, tapos fit to work or fit to
For school.
go into school na po siya.
Okay. So clarification. That's also for the workers po kasi I've been encountering patients sa City Health Office. Pupunta sila doon and they're asking for kung kailan daw sila pwedeng pumasok. And, personally, ang alam ko po ay 2 weeks. So, ano na rin siguro na that's for our City Health. And siguro pwede na rin natin yun ma-disseminate naman na they are contagious for the 2 weeks as long as pag hindi pa po sila. Pero pag start na po ng treatment nila, they just need to wait for 2 weeks. Pwede na po silang pumasok. Ang treatment po nila ay aabot for 6 months. Pero for the first 2 weeks lang sila nakakahawa as long as tuloy-tuloy po yung gamutan nila. Important is yung tuloy-tuloy po na gamutan. And yun po, and yun, hindi na sinasama-sama ma-stigmatize for the duration kasi yun yung problem natin. Kasi mas natatakot sila pumasok kasi nahihiya sila pumasok kasama yung mga nila kasi baka mahawa nila. And natatakot din sila kasi syempre sila parang for them na nahihiya rin sila pumasok kasi iba na yung tingin sa kanila ng mga kasama nila. Pero that's also one thing na siguro we can work on this stigmatization of TB patients because TB is a very treatable disease and hindi siya talaga ang nangyayari we just tinatago natin kaya po mas lumalala yung kaso. Pero once we reach out na hindi po dapat tayo hindi po tayo nahihiya. And it's the same with other diseases. It can be treated and it should be treated para hindi po lumala. Meron pa pong questions from ano po? Sa atin po sa body. Yes po, sir.
Hello. And sir, Doc, apart from the financial assistance that we can provide, considering din po yung mga non-monetary concerns na possible na i-raise ng mga patient. I mean, in terms of mental health po, syempre may mga stigma and all na po nila ma-experience with all the stresses na dala ng kanilang sitwasyon. Since we are offering also counseling and psychosocial support, mental health po, psychological first aid. So, yun po pa siguro yung pwede namin din may offer din sa kanila. Sa kanila is immediate family members kung pinakailangan.
Siguro take note na lang po sa atin sa TB team para at least if they see the patient is really in distress, we can refer them to also do CSWD for psychological first aid. Thank you.
We have workers din po na trained for that. Thank you.
And ayun, not only just the City Health Office, can the private practitioners from ONP, can they also refer for those? Okay, sige po. Ayun. May mga, ano pa po tayo, may mga insights po tayo galing po sa ating ibang representatives. Baka po meron kayong gustong sabihin. Ayun. So, basically, yun po yung ano natin. This is an avenue for us really to talk about and to talk and collaborate with each other, to share insights, share our thoughts, and to talk if we have problems so that we can uh, solve it side by side with each other, especially in treating po our TB patients kasi di ba, yung main focus naman natin dito would be our patients. Yes po, Ma'am Joy.
Para po to sa sa school. Doktora, halimbawa kung may pasyente, kayong TB patient, pwede ko sila kumuha din sa clinic ng gamot o sa amin yan?
Ma'am, kasi po sa amin, wala po. So, I think, sa inyo ko na lang po i-refer para po yung kanilang
Okay.
Sige po, yun, Clara na rin po. So, so pag learner po kaya, saan kaya sila ano po ang, ano natin, to the nurses, ang school nurse ang magre-refer o sa i-refer ng PHW from their respective barangays? What do you think is better? Kasi yun yung gusto po sana rin natin, mas streamline yung services natin. So, kunwari, ganun, ano po bang mas madali kaya para mas madali sa patient? Do you think?
My opinion,
Siyempre, opo.
iba kasi patients, mas prefer nila yung barangay doctor
Okay.
compare sa school nurse. Kasi yung stigma kasi doon, di ba? Pag pumasok ka sa clinic, minsan may stigma doon. So, usually yung mga pasyente namin, prefer nila po yung galing sa barangay.
So, paano po kaya natin yung Doc, yung for example, yung school nurse po ba ang sasabi sa learner, yung teacher, or paano kaya natin sila mai-instruct na pumunta sa barangay health worker?
Kasi sa amin po, out of 101 schools, we only have 8 nurses.
Okay.
So, hindi po siya
Talaga kaya.
1-to-1.
Opo.
Kaya po madalas, sinasabihan po namin yung school to coordinate talaga with the barangay,
Okay.
mga BHWs. So, I think tama po si ma'am na mas maganda sa barangay na lang po. If ever naman po, yung mga school clinic, actually mga school clinic po is teachers, so designated lang sila. We also have orientations na yung mga learners, meron po silang nakatang any symptoms, lalo na po doon sa malalayo, they can refer it na lang po agad doon sa
PHW.
Yes po.
So siguro on our part, siguro magpakilala na lang yung mga PHW natin sa mga teachers in charge sa mga schools para they know. Sige po. So, can we put that doon sa action notes po natin yung introduction ng mga PHW with the teachers in charge in the barangays. Yes po daw.
I would like to pose a question to the City Health Office regarding the referral system as what we are experiencing sa OLP. There are certain instances na when we refer our patients to City Health for enrollment sa DOTS, kasi we are aware na meron ng certain days like Tuesdays and Fridays, tama ba? Na they can go there and be accommodated. Pero there are certain instances din na hindi sila umaabot sa cut-off. Some patients, in fact, most of the patients would be sputum positive. Pero pag pumunta sila doon, nagkakaroon ng problema sa pagpalista, hindi sila ma-accommodate kasi meron ng cut-off. So I was just wondering if it would be possible to improve on the system pagdating sa pag-accept ng mga referrals. Kasi I can understand the cut-off system dahil overflowing naman talaga. Pero for TB patients na diagnosed case na, i-enroll na lang sa program, pwede ba silang ma-streamline para hindi na sila babalik on another day? Usually kasi what we are referring to, the city health offices are from the far-flung barangays. So yung medyo malalayo talaga, kaya hindi sila ma-enroll sa OMP. So pag ganyan, pabalik pa sila, kung pupunta sila ng Tuesday, babalik sila ng Friday. Kasi hindi na sila umabot sa cut-off ng Tuesday. So hindi ba sila pwedeng everyday. Basta TB patient, hindi sila kailangan sumama sa cut-off number ng pumipila.
Doktora, noted po yan. Siguro po yan nangyari po noong time sa COVID. Kaya lang ngayon po, nagkaroon na po kami ng usapan or last meeting na only na po ang patient as they come na. Tapos yun po sinasabi na Tuesday or Friday, yun lang po yung follow-up sa mga TB patients. Pero yung mga new cases po, daily po yung tinatanggap. Or halimbawa, sa hapon na po, binibigyan na po ng initial dose. Tapos pinababalik na lang for contact tracing, lalo na pag positive. Try yung mga referral nyo po, nagre-return slip po ako. Kaya lang, ang problema kung ginabalik.
Naka-ano pa yan tinetext pa yan ni Ma'am
Opo.
So, wala namang problema sa return slip. Yun lang mga cases nga na bumabalik sa amin kasi hindi sila na-accommodate kasi na-cut off na daw sila. So, they're
Baka
trying to come back another day.
Noon pa po siguro yun. Pero ngayon po, hindi na po nangyayari.
Thank you.
Thank you din po.
Okay, so yung take home po ay, pwede na po kayo mag-refer. Well, wala pong problema. Sa referral, so ganun na lang po. So, ayun. Meron pa po questions? Ayun po. Meron po tayo naman nakuha action points for today. And hopefully, we will just be giving you feedback na lang po with the action points that we will be having. One is yung with CSWD, yung with CTDFL. Po. May mga questions pa po tayo? Okay. So, I guess wala na po. So we'll just have a 2-minute break. We'll just kindly answer lang po yung ating QR code and we'll come back. Ako na po yung magsi-speaker list. So, ano lang po, pa-evaluate na lang po. And you can also drink coffee and yung CR break po muna tayo. And we'll come back after 2 minutes. Thank you. Okay, so we're down to the last session po of our of this morning's activity and last session. So konting tiis na lang po, lunch tayo dun sa baba. For now, I want to introduce myself po. I'm Dr. Ralph Marco Flores, one of the newest doctors from the City Health Office. I'm also the one handling for the universal healthcare integration of the city of Puerto, Princesa. So we are taking this opportunity na din to inform the stakeholders in the TV program of what universal healthcare is and its consequent changes in the landscape of the changing of the landscape in Puerto Princesa. And afterwards, I will also be orienting you with the PhilHealth Konsulta. So wala po akong, just to give you a brief overview on universal healthcare. The universal healthcare, kung narinig niyo na po siya, was passed into law on February 19, 2019. And its IRR was released last October then of 2019. Dapat po talaga nag-integrate na po tayo. Meaning po nung integration, gumagawa na po tayo ng mga strategies. Ginagawa na po tayo mga bagay para po ma-implement yung universal healthcare dito sa atin. So actually po, itong event na to 3 araw and yung nakaraang 2 araw po na nangyari, napag-usapan po namin kung paano po yung magiging referral. Hindi lang po ng TV, pati kung paano po yung magiging takbo nung healthcare po dito sa atin. And that's the Puerto Princesa Healthcare Provider Network. Pero ngayon po, ang gusto ko po i-focus sa inyo ay yun po, yung universal healthcare at paano po ito makakabago sa atin. Ang universal healthcare po bilang batas, ang minamandato po sa atin na dapat po, sinasabi po ng batas na lahat po ay lahat ng Pilipino ay rehistrado sa PhilHealth. Meaning po, wala na pong, hindi na po siya, kailangan mandatory na po yung registration. Whether or you like it or not, you will, kung may kaya ka man o wala kang kaya magbayad, lahat po ay dapat rehistrado na po sa PhilHealth. Yun po yung sinasabi natin, yun po yung pinaka spirit, kaya po siya tinatawag na universal healthcare. Kasi universal, meaning lahat po. Lahat po ng Pilipino ay nakakatanggap ng serbisyong pangkalusugan na hindi po sila dapat naghihirap. At yung serbisyo po na matatanggap nila, hindi lang po katulad ng dati na curative. Kumbaga, ngayon po sa universal healthcare, preventive, promotive, curative, rehabilitative, palliative, lahat po ng iyon ay kasama na po sa universal healthcare at ang mandato po nun sa amin sa City Health Office na dapat po maibigay namin lahat ng serbisyo iyon. At kung hindi namin maibigay, kasama po natin ang ating mga private na kasama po sa mga hospitals, mga specialista na private, lahat po sila ay kasama din. Kukontrata namin sila para po, yun po, kumpleto po yung maibigay na serbisyo sa lahat po ng taga Puerto Princesa. Yun po yung talagang mandato po ng universal healthcare sa atin. At sa TV, syempre, dahil ito po ay para sa TV, ganun din po. Mababago po ang TV sa pamamagitan ng po na katulad kung dati po ay kung sa dati, wala na rin naman po talagang binabayaran kasi DOH yung nagbibigay ng gamot. At sa amin po sa City Health ay nagbibigay naman po kami ng libreng laboratory at consultation. So wala naman po, medyo pagbabago doon. Pero kung ang proseso po, medyo doon po tayo magkakaroon ng pagkakaiba. Ngayon po, nagbabago na po yung sa PhilHealth, meron na po silang reforma sa PhilHealth na pagbabago po kung paano magbayad, kung paano babayaran sa mga doktor sa hospital, yung hospital mismo, at kung paano po rin kami babayaran sa City Health. Yun po. Basically, yun po yung orientation natin. Medyo malawak po kasi yung universal healthcare. Pero ito po yung gusto kong i-orient sa inyo ngayon. Yung consulta package. Ito po yung isa sa mga proseso na pinagbibigyan ng focus ng opisina namin sa ngayon. So, ito po ay konsulta or yung sa PhilHealth po, meron po tayong tinatawag na konsultasyong sulit at tama or konsulta package. Kung dati po naririnig niyo yung primary care benefit package, kung kayo po ay nagpapacheck up para po sa mga sakit katulad ng hypertension, diabetes, mga ganun pong sakit, dati po may binibigay po yung PhilHealth at nililibre po ng PhilHealth o may binabayaran porsyento po yung PhilHealth para makatanggap po ng libreng gamot, konsultasyon at laboratory ang mga patients. Ngayon din po, ganun din po with the universal healthcare. Mas i-expand lang, mas papadamihin yung mga serbisyong ibibigay. So, sige po, tingnan po natin kung ano po yung pagbabago. So, katulad po ng sinasabi ko kanina, ito po talaga yung mandato po ng Universal Healthcare Law na every Filipino shall be granted immediate eligibility. Immediate eligibility na lahat po ng, yun nga po, na lahat ng Filipino ay meron na po dapat PhilHealth. At meron po sila access to preventive, promotive, curative, rehabilitative, and palliative care for medical, dental, mental, and emergency health services. Meaning po, hindi na po tayo focus lang sa paggagamot sa pasyente. Sa preventive, nag-focus na rin po kami, focus po tayo sa hindi na po pagkakaroon ng sakit, pag-prevent po ng sakit, at ganun din po sa paggagawa po ng environment na mas healthy or healthy environment. Kaysa po sa curative tayo papasok, doon po sa preventive, isa rin po yun sa focus ng universal healthcare. Kaya ngayon po, binibigyan din po ng focus ang health education and promotion sa universal healthcare. Yun po, delivered as either population-based or individual-based health services. Pag sinabi po natin population-based or individual health-based services, meron na pong dalawang serbisyo na tinitignan ngayon yung PhilHealth. Population-based at individual-based. Pag sinabi po natin population-based, ito po yung mga serbisyo na nakaka-apekto po sa populasyon o sa mas maraming tao. Katulad po ng mga pag-control po ng mga vector-borne diseases, dengue, yung po yung pagbibigay po ng mga sa pag-control ng dengue, sa environmental health, yung disease surveillance and epidemiology, health promotion, yun po lahat ay papasok sa population-based services. Pag sinabi naman po natin individual-based services, naka-akla po siya sa tao. Yung binibigay natin kada individual. For example, consultations, counseling, pagbibigay po ng gamot at saka po ng laboratory, yun po ay individual-based services. Sa PhilHealth po, papasok individual-based services, meaning lahat po ng individual-based services na ibibigay po ng isang healthcare provider ay babayaran po ng PhilHealth. Para po wala nang bayaran yung mga pasyente natin at hindi po sila mahihirap. So, yun po. So, ngayon po, paano po ba tayo pwedeng mag-register sa PhilHealth? Ano po hindi po ako taga-PhilHealth. Pero isa po ito sa mga servisyo na binibigay namin kasi in relation po with the universal healthcare kasi nga po, ang mandato po ng universal healthcare na i-registro lahat sa PhilHealth. So, tinutulungan po namin sila ma-registro po lahat. So, kailangan po talaga kasi yung PIN. Bakit po kailangan yung PIN? Kasi yun nga po yung magiging numero nila. Unique po yun sa lahat. So, pwede po yun na pwede po nila yung gawin sa magiging primary care provider of choice or sa bago po, siguro hindi nyo po naiintindihan yung primary care provider. Sa ating pong healthcare provider network, magkakaroon po kasi tayo ng healthcare provider network. Pag sinabi po natin healthcare provider network, para siyang pyramid. So, mas marami po yung sa baba, sa taas. So, meron pong different levels of care na tinatawag. Meron po tayong primary, secondary, tertiary, specialized care. Tapos meron pa po yun dito. So, sa universal healthcare, binibigyan na po nila ng importansya yung healthcare providers network. So, meaning po, sa primary po, yun po yung nagbibigay ng basic na serbisyo na kaya pong, na basic na serbisyo na kinakailangan po ng karamihan ng populasyon natin. Sa primary care, sila po yung kayang gumamot ng high blood, diabetes, yung mga basic po ng sakit, sila po dapat dadaan dito. So, sa primary care. So, meron po yan dito, yan po yung tinatawag natin primary care provider. Sa primary care provider po, dyan papasok yung ating mga doktor, mga general physicians, yung ating pong doktor sa PhilHealth, yung mga iba pong doktor, at saka yung mga specialista po na gusto mag-provide ng mga basic na serbisyo. Pero, pag hindi na po kaya ng ating mga primary care provider, kailangan po silang i-refer o kailangan po natin silang idala sa mas mataas na level of care. Meron po yung secondary at tertiary care. So sa secondary care, dyan po papasok yung ating mga hospitals like for example, level 1 hospitals and yung level 2 hospitals. Dito po sa Palawan, meron po tayong mga level 2 hospitals. Lahat po ng mga hospitals natin ay level 2, katulad po ng AIM, Co-op, Adventist, and Hospital ng Palawan, lahat po sila ay level 2 hospitals. So, pag medyo komplikado po yung sakit, na hindi po kaya gamutin ng primary care physician, pupunta po sila sa, yun nga po, sa level 1 or level 2 na hospital. Tapos, pag hindi pa rin po kaya, ililipat po sila sa tertiary at saka po sa Apex Hospital. Pag sinabi po natin tertiary, yun po yung mga level 3, yung mga malalaking hospitals. At yung Apex Hospital po, sila po yung talagang mga specialista po, yung talagang mga sa heart center, yung mga nagagamot po na para po sa mga pinaka-komplikadong sakit. At sila lang po yung mayroong mga up-to-date na teknolohiya po sa paggagamot. So, bali po, pag sinabi po natin primary care provider of choice, sila po yung unang pupuntahan po natin. At sa PhilHealth po, pagbabago po sa universal healthcare, lahat po tayo ay dapat nakarehistro sa ating primary care provider. So, hindi ka po pwedeng pumunta ng hospital, gusto mong magpa-check up kasi sabihin mo masakit yung dibdib mo. Punta ako sa cardio. Hindi na po pwede gano'n kasi yung cardio, di ba, specialista sa puso. Hindi po pwede na gano'n. Sa universal healthcare, kailangan po magpa-check up muna kayo sa inyong primary care provider. Sa ating general physician, sa ating pong doctor sa City Health or kahit po sa private. So, kailangan po silang pumunta kayo doon bago po, at sila po ang magre-refer sa specialista. Kung pwede naman po sa hospital kung ito po ay emergency. Kung emergency po, at saka po kung malayo yung primary care provider nyo, kunwari, nasa Iloilo pala kayo, pero yung doktor po ninyo ay nandito sa Palawan. Siyempre, kung kailangan nyo po magpa-check up, exception po yun. Naintindihan po? So yun po yung primary care provider. Pwede po tayo magpalista sa kanila. Pwede din po sa, ayun po, or pwede po sa PhilHealth mismo. So, ang pagre-rehistro po sa konsulta ay once a year. Meaning po, kailangan po natin silang isang beses lang po sa isang taon nagpaparehistro. Pero sa loob ng isang taon na yon, doon ka lang po unang check-up, yung unang check-up nyo lagi ay manggagaling po doon sa primary care provider po ninyo. So, ganun po siya. Sige, okay na po yan. So, katulad po nito, pag nagpaparehistro po tayo, di ba po, isang taon siya. Tapos, ang updating po natin, pag sinabi po natin updating, may dalawa po yan. Pag gumamit po kayo ng Konsulta package or nagpa-check up kayo sa isang taon, automatically next year, pwede po i-register po kayo sa same na doktor. Pero, kung gusto niyo pong pumalit, pwede po kayo magpalit ng inyong doktor pagdating po sa fourth quarter po nung taon. Para po, iba na po sa next year. Pag hindi po nakapag-update na yun po, failure to update the registration, pag hindi po nakapag-update, automatic po na i-register kayo sa same na doktor. Yun po yung failure to automatic registration sa same na doktor. Pag hindi po kayo gumamit ng benefit, hindi kayo nagpa-check up, sa loob, for at least 18 months, magiging inactive po kayo for the last 6 months. Kailangan po ipa-update. At for the 2 years po na hindi magpapa-check up, tatagalin po kayo sa listahan, kailangan nyo po magpa-rehistro at gawin po yung proseso all over again from the start. So, kung meron pong magsara naman, kunwari magsara yung doktor or yung primary care facility kung nasaan kayo, yung PhilHealth po yung bahala na ilipat kayo kung kaninong doktor po kayo ililipat. Sige, okay. So, ito po yung sinasabi natin na ang benefit po ng Konsulta package ay yung individual po na services, pagbibigay ng gamot, ng laboratory, at saka po ng gamot, laboratory, consultation, ibibigay po natin yon. So yun po yung sinasabi ng Power Individual-Based Services. And access to select diagnostic services, hindi po lahat mabibigay namin. So pag sa primary care, hindi naman po mahirap naman po ibigay yung buong lahat ng laboratories, hindi rin po yun, meron lang pong select na diagnostics na pwede pong i-cover po ng PhilHealth. Pwede pong gumamit po na ng telemedicine, yung doktor ninyo, kung hindi na kailangan pumunta sa clinic, kung gusto niyo magpa-check up, pwede po yun, pinapayagan po yun ng batas. So, aside from that, dapat po yung mga doktor niyo na primary care provider, kailangan pong nagsiscreen. Kasi nga po, ang focus natin ay preventive. So meaning, dapat ini-screen na bago pa po kayo magkasakit, na-screen na po. Alam na kung meron po kayong risk factors, tinitignan na po yung mga risk factors para po ma-screen kayo. Nagdedepende po yun sa edad ninyo at kung kayo ay babae o lalaki. At yun po, yung package naman, continuously na i-improve kasi alam naman po natin, dumadagdag yung presyo, mga ganun po. So, it will be constantly reviewed po ng ating Health Technology Assessment Council. So, ito po yung serbisyo na ibinibigay, na pwede pong ibigay ng ating mga doktor sa primary care. Consultation, provision of preventive services, assisting beneficiaries to accessing other services, and referral to specialty in higher levels of care. Yun po yung pinaka-gist actually nung mga kasama po namin kahapon, kasi yung mga kasama po namin kahapon, talaga po ay mga doktor. So mas pinag-usapan kung paano yung pag-refer from one to another. So kasi yung primary care provider po, sila na po yung magiging care navigator ninyo. Meaning, kung kayo po ay maging pasyente, ang primary care provider po ang dapat nakakaalam kung kanino kayo i-refer. At the end of the day, it's still patient's choice. Pwede niya kayong bigyan ng, kunwari, nakita po kayo ng primary care provider at kailangan niyo po ng check-up sa isang specialista, kunwari kailangan niyo ma-check up ng isang pulmonologist. Alam niya po, yung primary care provider ninyo, expected po sa kanya na alam niya yung lahat ng pulmonologist po na kung saan niya kayo pwedeng i-refer. At at the end of the day, kayo po yung pipili. Bibigyan niya kayo ng choices at kayo po yung pipili kung kanino niyo po gusto ma-refer. So sa laboratories po na meron na pwede na pina-cover din po ng Konsulta, kasama po doon ay CBC, urinalysis, fecalysis, sputum microscopy, fecal occult blood, pap smear, lipid profile, fasting blood sugar, or glucose tolerance test, ECG, X-ray, creatinine na HbA1c. Kung nakikita niyo po, yung mga diagnostics po na kailangan po ng 4 TB workup ay kasama po dito maliban sa Gene Expert. Pero yung Gene Expert naman po kasi ay free. So okay lang po yun. At meron din pong mga gamot, katulad po, meron lang pong basic medicines na supposed to be magiging libre na po siya with the Konsulta package. Antibiotics such as amoxicillin, coamoxiclav, nitrofurantoin, cotrimazole, ciprofloxacin, clarithromycin, oral rehydration salts, salbutamol, prednisone, fluticasone plus salmeterol, paracetamol, simvastatin, gliclazide and metformin, mga anti-hypertensives po natin katulad ng enalapril, metoprolol, amlodipine, hydrocort, losartan, aspirin, and chlorpheniramine po. So lahat po ng iyan ay pwede pong makuha ng pasyente. Kasi ang balak na po natin, pag rehistrado po kayo at meron na po kayo magpapacheck up kayo, doon na po lahat. Punta na kayo doon, wala na kayong babayaran. Makukonsulta kayo, malalaboratory kayo, mabibigyan kayo ng gamot. Paglabas niyo po doon, iinumin niyo na lang po yung gamot para kayo ay gumaling. So, pero, ang kailangan lang po sa mga pasyente, dalawa lang po. Yun po, kailangan nilang magpa-register. At pangalawa po, kailangan nila magkaroon ng Authorization Transaction Code or ATC. Meaning po, kada pa-check up nila, kailangan nila mag-secure ng Authorization Transaction Code sa PhilHealth. Pero kung wala naman po, sa amin, tinatanggap naman po na mag-walk-in yung pasyente, pipicturean lang po namin sila. Tapos, bago po sila umalis ng konsulta, meron lang po silang sasagutan na customer feedback at saka po na signaturean lang po nila yung kanilang prescription form. Ayun po. Sige, okay na po yan, sir. Kasi ano. So yun po, meron kami yung gusto po natin, lahat po yan, meron po, nakikita po natin na meron po improved health outcomes, increase po yung coverage natin to medicines, and magpo-provide na po tayo ng preventive screening. Yun po talaga yung pagbabago sa parte namin kasi required na po kami mag-screen ng lahat po ng pasyente. And yun, mag-utilize po ng ating primary care and basically bigyan niyo po kami ng feedback sa amin sa trabaho po namin. So sa amin po, yung magagaling po sa PhilHealth, pwede po namin yung gamitin para sa pagpapaganda pa po ng servisyo namin. Pero pwede din po kasi may private nga po na consulta providers or primary care physician. So kasama na po doon yung PF nila for laboratories and medicines din po. Ayun. Sige po. Bale, yun po talaga yung magiging focus ng PhilHealth. And ang gusto ko pong iparating dito ay meron na po nga ganitong programa ngayon. At ito pong programa na ito, cross-cutting katulad nga po, lahat po tayo ay maapektuhan. So, tinignan po namin yung opportunity na to para po ma-introduce sa inyo na may ganito na po. At sa Universal Healthcare, lahat po tayo ay sama-sama. At sa Universal Health, wait lang po pala. Ito pala po yung PKRF or PhilHealth Konsulta Registration Form. Ngayon po, bale, meron na po, di ba po, pag kumuha tayo ng PhilHealth, meron po tayo sinasagutan ng PMRF or PhilHealth Membership Registration Form. Yun po yung PMRF, yun po talaga yung pagpaparehistro natin sa PhilHealth. Ngayon po, with the Konsulta package, meron na po tayong tinatawag na PKRF or PhilHealth Konsulta Registration Form. So sa PKRF naman po, ang re-registrohan na po natin ay yung primary care provider o yung doktor kung saan po tayo magpaparehistro. So pag may PMRF, okay na po. Pero kada taon nga po, kailangan yung mag-register ng PKRF para po kung saan yung gustong doktor na kayo magpapacheck up. Okay po? So meron na po tayong PKRF. Yun. Ayun, okay na po. So, ayun po. Ulit. Bale sa atin po, yung universal healthcare nga po ay yun na po yung, kumbaga kasi, doon na po tayo patungo. So whether nasa education sector, sa marginalized, or sa employees, lahat po ay i-register sa PhilHealth. Kung hindi man po sa City Health Office, kayo po ay dapat maparehistro yung ating mga constituents sa isa sa mga primary care providers para po sila po ay makatanggap ng serbisyo sa healthcare. Kasi po, kasama din po kasi namin nung nakaraang araw yung Senior Vice President po ng PhilHealth. And sinasabi niya sa amin na kung hindi ka po kasama dito, kung hindi po kayo registered, pag magpapacheck up kayo, talaga pong malaki ang bayad. At makikita niyo po yung diferensya kasi kung naka-register kayo, wala na po kayong dapat gawin kasi kung nagtatrabaho kayo, ang bayad naman po ay nandoon po sa mga employers po ninyo. And pag indigents naman po, gobyerno naman po ang magbabayad sa inyo. And lahat po ng serbisyo na ngayon ay magiging libre. So wala pong lugi kung kayo po ay magpaparehistro lang. Wala pong problema kasi magsusulat lang po kayo tapos kami na po ang bahala. Kung meron pa po kayo kailangan, kung kailangan po ng mas mataas po na level ng serbisyo, kami na rin po ang magre-refer at hindi na po kayo mahihirapan na mag-shopping pa ng doktor, pumunta sa iba't ibang lugar. Kasi trabaho na po yun ng primary care provider. Nahanapan po, i-refer po kayo sa tamang lugar, sa tamang tao. Okay po? Yun po. Bali yun po talaga, and with the TV, hindi lang po kasi siya sa TV, kundi sa lahat nga po. Meron po, with that I end po my presentation. Meron pa pong questions? May questions po tayo. I hope, po, para po maklaro po sa atin, ano po ba ang, yes po, Doc.
Doc, ano po yung specific relevance niya sa TB program?
Ayan.
I-apply natin si Konsulta package na TB talaga.
Opo, yun nga po, Doc, dito na po kasi namin ipapasok yung mga laboratories niya sa amin po. Kasi minsan, pwede po yung mga x-rays po and everything, yung ibang lab diagnostics po niya ay di ba pwedeng gawin sa labas. So pag pag primary care provider, dapat po marunong siya mag-work up po ng TB. So para hindi na po mag-ikot-ikot pa yung patient sa lalo na po sa mga primary care providers. Kasi po, mangyayari po, kailangan po, pag ikaw ay primary care provider, dapat po ikaw ay nasa isang primary care facility. Yung primary care facility, yung nagpo-provide po ng diagnostics, laboratories, and everything po. Tapos po siya na po ang process na po ay i-refer niya na po sa CHO para po sa yung mga gamot po. Kasi sa transition plan, it's still with the DOH po pa rin po yung gamot ng TB next naman po. Basically, cover lang po talaga yung payment po for both public and private po na mga patients.
Tama na ba ngayon yung Palawan sa pilot areas?
Yes po. Currently, sa City Health po, kami po ay primary Konsulta provider na po. So, pwede po pwede niyo po i-register sa amin para po yun po yung mga diagnostics na yun, libre na po yan. Kasi covered na po, kami po ay Konsulta provider na po, City Health Office. Pwede private po, pwede na rin sila mag-apply. Actually, since last year, meron na rin po Aborlands, is a big Konsulta provider. Other municipalities, meron din po Konsulta providers na din. Yes po.
Dok, tulong din ako sa sagot mo.
Sige po. Sir,
Kasi actually, kailangan ko talaga yan. Sa sinabi niya, dito kami yung screening pa lang. Importante yung member ka ng PhilHealth kasi pa mag-credit lahat ng effort nila ng PhilHealth kasi pinabala ng PhilHealth sa isang aspect. Another aspect is of course doon sa PhilHealth program na really accredited din po at ang City Health Office no? So dalawang services na dapat nila i-provide sa isang member. So mahalaga po yun talaga yung topic na yan para sa PhilHealth program.
So yung question ko kasi, pertaining to hospital ng Palawan, Kasi we have a PPC program, pero I'm not familiar with how Konsulta will be applicable to OOP setting. Kasi hospital po kami, secondary provider, secondary level, level 2. So, right now with this discussion, how can ONP be a part of the Konsulta package?
So, may separate ba kayong PBDOS program? Meron din, no?
Opo.
So,
Meron po kami sa accredited with PhilHealth, kaya meron po kami sinasabit na claim. Pero with the Konsulta package, is this a different form of program pa na pwede pa rin ma-avail ni ONP other than the PhilHealth package, PhilHealth outpatient package?
yes po, kaya lang ang mahalaga po doon, ang basic requirement dapat ay accredited si
Kung
ONP
mag-apply na
sa Konsulta package. That's why yung nilidesign ni Doc ay tungkol dun sa kanilang verification dahil kasama yun sa gusto nila i-deliver ng mga service ng CPL.
So sir, bali sa Konsulta package, the agency or the institution can avail of both. Hindi siya magkakaroon ng conflict na this patient availed of the TB outpatient package, tapos pwede pa siyang mag-avail ng Konsulta package.
Yes.
Kaso dalawa.
If I may, yung Konsulta package po will be for the primary care providers po. So, based po sa naging usapan din po, ang ONP po talaga, ang outpatient kasi will be, katulad po ng discussion kasi kahapon, will be focusing more on the subspecialty and specialty na po. And yung TB dots po kasi is a separate po talaga siya na package. So, pwede po talaga niyo yung i-apply. Pero yung Konsulta package, I don't think pwede po siya kasi pang primary care providers po siya.
So sa ONP, we can only apply kasi existing na po yung
TB
outpatient package. Pero for the Konsulta, we don't have to apply.
Yes.
Or we are not qualified to apply.
Opo, kasi po, kayo po ay secondary care provider. Yes po. This is basically po for the primary care providers po. Kasi it would be,
Doc, clarify ko lang open yung ONP sa Konsulta accreditation.
Talaga po.
Pwede. Actually yung Police Sanitarium is accredited din sa amin. So the same po pwede. Pwede open po sa lahat ng facility. Provided meron silang primary care na service.
Kung primary care, meron naman po talaga si ONP. Kasi we cannot be secondary if hindi kami dumaan sa primary.
Kaya ako actually nag-invite kami sa kanila na to file for accreditation, to apply for accreditation. Nag-aantay lang po kami sa kawan.
Ayun po, pwede po. Pero with the discussion po namin nung the previous day, really, nasabi naman din po ni Dr. Pargas na hindi pa po, ito yung final. Actually, po, the package will be transformed into another package. It's comprehensive outpatient benefit package now po. So this is still not a final transition for the UHC. And we will see in the near future of how it will be implemented din po talaga. Kasi now everything, ito po ay transition lang din po. So we'll see in the future kung paano po yung magiging na po natin.
Kaya po na-kuha ko rin po yun na narinig ko yung sinabi ni Doc na parang preparatory niya po ito yung program na to sa network. Kasi eventually, sila magiging sila mag-constitute ng network yung mga accredited na facilities.
Yes. So yun po. Kasi basically ma'am, yun po ang iba pang discussion ay yung healthcare provider networks. All the hospitals will be formed in network. And yung PhilHealth po will be paying the network and not the hospital themselves po in the future. So, yan po yung isa rin, payment mechanisms, yung hati-hatian. So, nasa network na po yun. Sir, thank you po. May questions pa po? Yes po, no?
Dapat pagkaroon ng PCP kasi
PHU, Public Health Units po. Yes po. Yung Public Health Units po kasi, they will be the ones na meron po care navigators, may disease surveillance officers, may social workers as navigators na po, nurses as... Apo, doon na po papasok. Doon po yung referrals nila would be with the care navigator po of the public health units.
So, another question. Yun po yung sa update ng PhD. Halimbawa daw, kasi kung minsan tayo makakalimutin, hindi mo na-update, tapos kailangan mo na pala yung services ngayon. Anong gagawin mo?
So, baka, I think Dr. Fred would be
Kailangan
better one.
Dok, hindi ko na-capture yung question niyo kasi may isip ako. Ano pa ba yun?
ano nga po yung months ba yun?
Ay, ano yan?
So, ano pinaka-gist Dok ng question?
Kaya na-failure to update the registration, pero sa moment na yun, kailangan ng services. Anong gagawin niyo para ma-avail yung services?
Actually, ang sinabi nga doon sa law ay immediate eligibility. Wala ng problema. Ang sinasabi lang po doon sa pag-clear to upgrade registration, doon po sa pag-register ng facility. Na in the event na yung isang patient ay happen na sa last day na kanyang accreditation o registration period ay dapat mag-choose na siya kung saan niya gusto. Kung hindi siya pipili, ina-assume ni PhilHealth na safe pa rin. So, gano'n. Opo, mga kapit. The same pa rin po, walang problema. Ang pagkakaiba lang po natin pag out of pocket usually, kapag yung isang member ay nagpalit o nag-change ng category from financially capable to financially capable individual. In that sense, magbabayad na yung ano. Kung ang sinasabi ko para pagkagan pag-hospital. Pagka sa konsulta naman po, wala naman po problema kasi yun ang binibigay ng program para dun sa benefit na gusto niya i-avail.
Apo. Yun po, kahit inactive po yung patient, pwede pa rin po sila mag-avail as long as it's with their registered po na provider. Kasi pag nagpili-pili sila ng iba, yun po yung tinatawag ni Doc Pargas na gaming. Parang you're gaming the system, nilalaro mo yung system. So they're still required to, they can still avail, but still with the same provider. They cannot choose bigla. Unless it's an exemption nga po, it's an emergency or proximity din po. Kung malayo sila sa provider nila.
Tanong po. Tungkol po, kasi naka-enumerate po kanina yung mga medicines po na available sa UHC. O paano po, Dok, kung hindi po nakapili yung doktor sa gamot na yan, meron siyang gustong iba, yun po ba ay sagot ng pasyente? Out of pocket po ba? Or sino magbabayad po nun? Halimbawa, nag-prescribe po yung doktor.
Ina-assume po ng PhilHealth na available pa mga gamot ganyan, dapat ipapainom sa kanila. Otherwise, iba naman po yung usapan mo.
Gastos po talaga kasi one of the things po is we are changing is not only patient behavior but also doctor's physician behavior. So, dapat po talaga pumili sila within this kasi kung hindi, they will incur losses.
Baka hindi na maging viable yung operation ng facility in terms of PPD.
Yes po.
Pagdating po kay PhilHealth, being a Konsulta provider, registered, accredited provider, sino po yung inyong mga partner facilities at saka partner specialists for our information?
Currently po sa referral, yun po kasi on the works. So wala pa po talaga yung ano. Pero basically, all the hospitals po kasi are very willing. Siguro ako, as I felt it, they're very willing naman to partner with us. And we'll see for next year kung how the network will work. So kung meron na pong network, yung referral system will be really basing on that. Kung sino po yung partners na makakasama with the hospitals and the private. Pero yun po, wala pa pong set in stone kung sino yung makakasama. But for us, ang ka-partner, ang ano na po, available siya lahat sa amin except for FOBT and ECG. Pero may ECG machines na kami, so baka next year tatanggalin na. And we're currently partnered with ONP po, with the FOBT. Pero yun lang yung service na wala kami po dyan ay yung fecal occult blood. Diba, Tita Gina? Pero bumibili na rin kami ng machine for that. So, hopefully next year, ma-provide na po namin lahat ng service. Yes po. Telemedicine. Ayun po, based kasi sa naging usapan, telemedicine, basta po, they are not in the same room, physically. So, pwede po yung telephony, or teleconferencing, telephone. Pwede po yun. That's a practice of telemedicine. So, wala pong, ang specify lang ng law is pwede pong gumamit ng telemedicine. And it can be applied to claim for consulta package. Pero yun po, wala pong specify kung paano details kung paano yung telemedicine. Kasi yung law naman po, I know, wala pong specific. Kahit po sa DOH na it's really, meron pong teleconferencing, telephony, mga ganun pong methods for telemedicine. Yes po. Hindi po.
As PhilHealth members, as government,
Opo, saan?
pa rin ba dyan?
Mag-apply
pa rin kami dyan?
Naka-ano na po tayo. Ano na po namin. Oo.
Sa mga, halimbawa po sa mga government teachers, di ba may PhilHealth?
Ay, opo. Di ba po may PhilHealth na? So, wala na po tayong problema with PMRF. Pero yung PhilHealth Konsulta registration form, naalala niyo po, nung nag-meeting tayo, may pinapinapan kaming maliit. Pero kailangan pa rin po yun kasi kailangan pa rin po kayong i-register sa inyong consulta provider. So, yung registration sa PhilHealth, separate po siya sa registration sa consulta provider. Opo, ano po? Opo, Doc, and yun po, yung mga sa workers natin, willing po kami makipag-partner. Kami na po pupunta sa inyo para po ma-register po kayo lahat sa PhilHealth Consulta.
Ano po yung procedure if yung mga teachers pa namin if they want to avail po yan?
Ayun po, pwede po gusto niyo po pwede po kami mag-orient, pwede din po namin silang i-orient, tapos pwede po namin silang bigyan ng form. Kasi ang form po na yun, kukunin namin, tapos ibibigay din po namin sa dinner.
So I'm sure yung marami po na interested for that.
Okay po. Yan po. At kaya po, sila Doc mag-orient. Sila Doc friend.
Yung actually, nung one time na galing ako sa Linapakan, lahat po halos ng teachers doon nagpa-register na doon sa Linapakan din. So, I will suggest na sana po dito sa Puerto Princesa, lahat, since sila naman po accredited na facility dito sa ngayon, lahat na po kayo ay
Opo. Wala naman pong mawawala. Oo, kasi wala naman po, at saka wala partners pa. Wala pang ibang providers.
Sige po, actually po kasi nung one week, kami ng orientation. So, dahil po ako nakikita sa kasama po namin sa proceedings na Dr. Hermeng and then sila Dr. Panginoon. So, hindi ko pa po kasi na parang ngayon lang siya na today. So, kung earlier siguro sana ito, na isama ko siya yung orientation namin yung bonding. So, siguro, Doc, if it's okay with you, pwede po namin siyang go. And kay Sir po, so we can set a schedule para po ma-orient po yung mga teachers namin. So, kami din po ang makakapagawa ng memo para po makapag-attend.
We are very willing po, ma'am.
Sige po, Doc, ito lang ikapalta ka.
Kay po, Ma'am Joy. Ma'am Eden, paano na lang po. Thank you po. Nice. Meron tayong action plans for today.
Saka ito para mas mabilis na pag-synchronize ito sa Linapakan. Before yung presentation, nakalagay na agad kung ano first choice po.
Opo.
Natak na doon.
Opo, nakarin sa kami. Meron po kami nakarin so. Susulat na lang po sila ng pangalan nila sa number. Yun po ang hihingi na lang siguro namin doon, ma'am. Kasi po, this is individual, aside from the paying member, pati po yung dependents nila. So maganda kung may MDR sila kasi po yung pins din ng mga dependents hindi din po. Ayan po, may questions po coming from our other members. Okay.
So, wala po i-share yung practice ng ganito ako. Yung malaking tulong din po na nagagawa ng PSW nila. Yung pagpa-register sa CPN. Apo. So, malaking tulong talaga para magamit ng PSW. Sige lang po. Registration, updating.
So, sige po. Tama po yun, sir, no? Pakasulat na lang para hindi natin makalimutan, i-orient natin yung mga PHW para sila mismo mag-ano din. Sila magpa-register din. Opo, magbabahay-bahay para. Ayan po. Basically, yun po ang ang gist. Marami po talaga mangyayari bago kahapon. Medyo mga nakaraang araw, medyo mainit talaga yung balitaktakan kung paano natin ito gagawin. At paano po i-connecta yung mga specialista, lalo na yung mga specialista at hospital, with the primary care provider. So hopefully, we got their commitments and target po namin is by May 2023, meron na po talagang Puerto Princesa healthcare provider na. So we'll be looking forward to that. May questions pa po tayo? Yes. Okay na ba yun? Wala na pong questions. So that ends our session for today and I'm very, very thankful for the presence of everyone. Maraming salamat po sa pagpunta. And very fruitful din po yung yung meeting natin today. In behalf po of Dr. Rick Panganiban, our City Health Officer, and Dr. Lee Palaka, our Assistant City Health Officer, and our Coordinator for TIFA, and Analiza Herrera, our Coordinator also for TIFA. We sincerely thank you all po for coming today. And marami po tayong action points. And I will personally commit to give feedback to all of you of what has transpired today. And we'll be sending na lang din po minutes of the meeting para po for your use. And with that, let's take a break for siguro 5 minutes. We'll just check kung okay na yung food sa baba. And before that, kindly skala lang po for QR code. Kindly evaluate na lang po me as your speaker for the last session. Thank you very much po. Okay, picture na. Sige, after po na evaluation, kindly lang po sit back, mag-picture taking lang po tayo and then we can go. Pwede na yung food. Okay, so after po ng 5-minute break, picture taking, and then we can go have our lunch sa baba, and then we can go na po. Thank you very much po. So evaluate na lang po agad para matapos na agad. Thank you po.
Sige, off ko na.
dito na po tayo sa harap just for a documentary picture. And then we can go down na po for our live. Sige po, dito na po tayo. I-ano mo na, check. Okay na yun. Ay, i-record mo. Tara na po. Tara na po. Opo, nagawa na ng parang ano ito may talagyan ko na ng computer. Dapat pati kahit na bigyan na yung unang ako na.
Hi. Hi.
That's 6,000 is what I'm 1.5 plus perfect. Parang yung maintenance. Parang 48,000. Hey! Hindi po. Sige, sige po, ayun po, maraming sa mga may certificate sa mga wala pa pong certificate of attendance materials. Ano lang po kayo sa likod. Sa ano po, kung meron na po, pwede na po tayong bumaba sa castle service po yung lunch natin. It's ready na po. Maraming salamat po ulit.